So, namaste to all. Greetings from Nepal. First of all, I would like to thank the Indian Society of Toxicology for giving me this opportunity to be a part of this webinar series. And it has been a really great learning experience personally for me. I'm Dr. Olita Shilpakar. I'm an emergency physician working in Kathmandu, Nepal. So I have been assigned to mention a few interesting case reports regarding grades. So hopefully I'll try to do justice. So to continue with the series of presentations, I would like to begin. So just coming on to the contents, I've listed the contents. So we'll be dealing with the introduction of the venomous snakes and the importance of identifying the different types of crates. We'll be looking at the case reports because the local manifestations, the systemic manifestations, these have already been dealt very well by the previous esteemed speakers. And regarding the diagnosis in the ER, the clinical symptoms, the lab diagnosis, and the immunological tests as well. Also regarding the management of Krait environment and its complications, a few cases on that as well, and a few slides on preventive measures. So just to in brief about the introduction part, this is the basic of snake bites. As we all know, it is an important occupational hazard and it affects the farmers, the plantation workers, herders, fishermen. And we all know that it's a life-threatening medical emergency, so we really need to be very fast in dealing with these cases. One thing I would like to mention is that the survival of the victims, they depend on the appropriate first aid measures and also the immediate transportation, which has already been mentioned earlier as well, to a nearest health center where the facility to at least administer an anti-snake venom if it is required, and also the supportive care, that is very much important. So I think we all are quite familiar with this excellent guideline by WHO regarding the management of snake bites. And we also have in Nepal also has a national guideline on snakebite management. It was published in 2019 by the Department of Health Services, by the Epidemiology and Disease Control Division. And we have been managing our cases, regarding this booklet as the base. And we also have a photographic guide by Professor S.K. Sarma et al., a very good guide on venomous snakes of Nepal with beautiful pictures in it. So I would also like to mention about an article which was published in Lancet in 2010 by David A. Worrell. I will not be going into all the details of this article, but I would like to mention that this is a very good article just for reference purpose. So we all know, coming on to the Southeast Asia region, the venomous snakes of the Southeast Asia region, if you talk about the taxonomy, three families of the venomous snakes, the Elapidae, Viperidae, and the Colubridae. I mean, not have to mention these in details. We all know about this. There's a book as well, guide as well, regarding the snake bites of Southeast Asia. And just a few pictures I would like to show about the medically important species in case of Elapidae, king cobra, Krait. In case of Viperidae, the medically important snakes, I've listed the few important snakes over here, Russell vipers, green peat vipers. In case of Colubridae, the medically important ones, this is a red-necked keelback. So these are wonderful creatures, beautiful creatures, I should say. So coming on to the Kraits, we all know, I've just listed the common names of the Kraits that are mostly present in our country, especially. The scientific names are also given in the table over here. The local names, these are all in Nepali. A common krait is known as a seto kalo churasarpa. Seto kalo means a black and white snake or sarpa. A banded krait, this is known as a pahilo kalo churasarpa. That is, pahilo means yellow and kalo is black, so black and yellow snakes. So these are some of the local names that we in our country we are familiar with. So these are again a few pictures. I'll just go through the pictures only because this has been beautifully explained by the previous speakers. Common krait, Bungarus ceruleus. This is the picture of a Himalayan krait. These are quite common in our country as well. This is a banded krait that I was talking about, the Ohilo and the Kalo, the yellow and the black sarpa, as we call it. And this is the lesser black krait, the Bungarus livitus. This one, again, greater black krait, the Bungarus niger. And this one is the Walls krait. So I would like to show an article that was published from Nepal. This shows the first record of dicephalism in the common krait Bungarus ceruleus from Nepal by Kamal Devkota et al. This was published in IRCF. So this shows actually the dorsal view of a dicephalic common krait Bungarus ceruleus. This is from a place called Kavasoti in Nepal, and this picture is a radiographic view of the lateral view of a dicephalic common krait from the same place, Kavasoti, Nepal. Some more pictures of the same dicephalic common krait. We can see the closer view of the heads of the dicephalic common krait Bungarus ceruleus. The first case of dicephalism was not a krait in Nepal, but it was of a keelback, and this is actually kept as a species, a specimen in the Natural History Museum of Nepal. So we all know why is the identification of snakes important. It has been dealt earlier as well. So there's no doubt that it is very important. It plays an important role to manage the patient firstly. The patient may be given antivenom unnecessarily in case we do not identify the snake, or if in case we do not know about the case. So identification of snakes is a very important thing. There has been an article published by Joseph et al. In first authenticated cases of life-threatening envenoming by the hump-nosed pit viper Hypnale in India in a journal, Transaction of the Royal Society of Tropical Medicine and Hygiene, where the hump-nosed pit viper was mistaken for a soft-scaled viper, and we don't have an antivenom for the hump-nosed pit viper. So I would also like to share one more article. This was published in the American Journal of Tropical Medicine and Hygiene in 2009. This talks about a syndromic approach to the treatment of snake bite in Sri Lanka, and it is based on the results of a prospective national hospital-based study of the patients envenomed by identified snakes. So there were 860 snakes brought to different hospitals, 10 different hospitals with the patients, and 762 were venomous. There were Russell vipers and hump-nosed pit vipers. These were the most common. And it is mentioned in this study that 51 of them, that comes out around 6% of them were misidentified by the hospital staff. And so what happened was they resulted in giving inappropriate anti-snake venom treatment of 13 patients in this particular study. So what I would like to mention here, that if we do not identify, if these are misidentified, if we do not identify the snake, so what we can do is distinctive clinical syndromes. In this study also, distinctive syndromes were identified to aid the species diagnosis, and the sensitivities and the specificities, the diagnostic sensitivity and the specificity of these syndrome were around 78% and 96% by Naja and 66% and 100% by Krait Bungarus ceruleus. So this was quite good. The diagnosis by the clinical syndromes. So again, why is it important to identify the snake. So if a dead snake has been brought, which in many cases we have encountered while working in the emergency as well, like in this picture, a dead crate is there. So if the dead snake has been brought, the first and foremost thing we do is just to identify the snake. But it requires real skill for identifying the snake, because even the experienced medical person, they may mistake the snake, some harmless snakes, for some venomous snakes. And also different venomous species could also be confused. So this is there in an article by Veeravan et al. And Ariyaratnam et al. As well. So what we have been doing in our scenario, in our part of the world, the image of the dead snake is taken. We all have mobile phones. It is sent by WhatsApp or Viber by a mobile phone to a local or a national or an international snake expert, if we are lucky enough. And if it is available, it can go to the Poison Information Center as well for a definite identification. So what happens if the snake is not brought? What if the snake is not brought? So there might be a problem if the snake is not brought, which is there. I think we have faced this kind of situation as well. So what we can do is the species responsible, it must be inferred indirectly from, if possible, from the patient or from the patient's relative, whoever has brought the patient to the hospital, by the description of the snake, if they have seen the snake, or by the circumstances of the bite. For example, in case of Krait's nocturnal bites, or in people sleeping on the ground, this again has been described in an article by Ariyaratnam in 2008. And again, the clinical syndrome, as I mentioned earlier, of the signs and the symptoms. So just in brief about the Krait, we all know this is a seasonal variation of bites. There we can observe that. And these bites are more common during the months of monsoon right now, I guess. And most of the hospital admissions are there. They follow, of the Krait bites, they follow rainfall, after falling a shower, after several months of drought. So this, I think, is the time. And regarding the important characteristics of the Krait, we all know the type of bites. Most bites, they are inflicted on sleeping victims. Could be anywhere from the trunk, scalp, face, genitalia, buttocks. This may cause minimal or even no pain at all. And this may pass unnoticed by the sleeping victim. And minimal or no effects. So it becomes very difficult at times to find the bites. And in some cases, we do not find any bites in these kind of patients. And we also talked about, in the earlier presentation, we also talked about the dry bites. Around 25% of all common bites, they encounter dry bites as well. So this actually is, I would like to show a case. This was in the Times of India in 2019, August 26th. It is about a Chandigarh girl, a sad story. I would just like to go in brief about this story. This child's father, Ram Karan, he was sleeping, woke up at around 5:30 a.m. to an unpleasant feeling. He felt very unpleasant because there was a slightly wet, a slowly moving creature kind of a thing on his bare chest. So firstly he flung it aside, and then he asked his wife to just switch on the light. And his wife thought that maybe this person is having a nightmare, but then she just switched on the light. And what happened was they were horrified to see a snake coiled on the bed at the feet of Ramkaran. And this cute little girl, Payal, 6 years of age, had slept beside them and without any kind of disturbance. And it is sad to say that by late noon, she had been declared dead at the PGI emergency. And it was really surprising for the kids' parents because if they had not noticed a very faint fang mark on her finger and symptoms of envenomation, had not set in till late 7:30 a.m. And then later they found this snake out. The snake was killed, and this was later identified as a common Krait. So features, we might not be, we won't be going in detail regarding the features. We know about the time of the bite, it's nocturnal, location mostly indoors. And I would like to mention one point over here. So we all know Krait bites, there are neurotoxicity, the Krait bites cause neurotoxicity at admission. But one thing which I would like to focus on is pain abdomen. because it is common in Kraits. It is common in 40 to 70% of the cases. And pain at the bite site, there is no pain or minimum pain at all. And local signs or any kind of swelling at the bite site, it is not seen in case of Kraits. So this actually is a flow chart. I would just like you all to focus on this box, because talking about the syndromes, we'll be dealing with the syndromes regarding the Krait only, the two syndromes, syndrome 2 and syndrome 3. These are the two syndromes. The first, the one, syndrome 2, nocturnal bite while sleeping on the ground and paralysis with no or minimum local sign of envenoming, or neuroparalysis associated with pain abdomen again, as I mentioned earlier. This increases the likelihood of envenoming due to a Krait. And in case of syndrome 3, again, neurotoxicity is there, but there might be dark brown urine, severe muscular pain may be there, but there may not be any kind of swelling, local swelling may not be there, bleeding or clotting disturbances, and there may be, or they with or without renal failure. And the person might, they may be giving history of being bitten on the land while sleeping indoors. So what happens after a snake bites? So clinical manifestation, just in brief about the clinical manifestation. We all know about the clinical manifestation, but I would like to mention again that there may be no clinical manifestation except the bite mark, or there may be no bite mark at all. And signs and symptoms could be due to traditional treatment as well. There may be local gangrene also, as we can see in these two pictures. This can be due to a tight tourniquet. This may also cause pain and swelling, congestion as well, and this might be confusing with the local envenoming. And there might be pain abdomen, vomiting as well, but this may be due to the traditional treatment that the people tend to give, especially in villages, by congestion of chilies or herbal medicine, and this might be confused with the venomous snake bites or the viper, the Krait bites. So how to identify a Krait? First of all, we could find, if we are lucky enough, we can find fang marks, as you can see in the picture. But Krait bites, they may leave no mark at all. So these can be nocturnal bites as well, and these usually occur to people sleeping on the ground. These bites, they do not cause any kind of local envenoming, and they can be virtually painless, because the size of the fangs, it could be equivalent to a hypodermic needle. So regarding the systemic manifestation, we've talked about the bungarotoxin in the earlier presentation as well. Krait bites, they present in an early morning. They get present in early morning with paralysis, and this can be mistaken with even a stroke. So Krait venoms, they contain large quantities of P-synaptic toxins, and they inhibit the release of acetylcholine by destroying the nerve toxins, nerve endings. And the features that we could get are nausea, vomiting, pain abdomen, malaise, weakness, drowsiness, prostration, even excessive salivation and all. So there was a question posted in the Poison Club as well. So very interesting question. Why do these Krait bites cause acute abdomen? So the answer, it has been already posted also as well, and has been already discussed also in the previous sections. The toxin, the muscarinic toxin, like proteins in the presynaptic neurotoxin, beta bungarotoxin in the Krait venom, this causes GI cramps, and this results in severe abdominal pain. And abdominal pain, as I mentioned earlier, it may suggest some mucosal hemorrhages as well in the stomach, and this is quite a common manifestation in case of Krait envenoming. And this feature, abdominal pain, might be the only and the earliest symptom in case of Kraits. And so there are high chances of us being misled, or this may lead to a misdiagnosis that whether a common Krait bite is suspected, if it is not suspected. So the best way is to get a detailed history as far as possible. So this is actually a research, again, an article that describes the contribution of ultrasonography to the diagnosis of internal bleeding in snakebite envenomation. They have mentioned ultrasound imaging showing internal hemorrhages like hematomas or hemiperitoneum, or a combination of both diagnosed by ultrasonography in case of snakebite envenomation. So how to identify the Krait? Again, systemic manifestation. I just listed the neurological manifestations here. Again, a few good pictures about the ptosis, inability to protrude the tongue beyond the incisors, and also the broken neck sign. These are a few interesting pictures here. So, coming on to a few case reports on Krait envenomation, complications, and management. So, let's discuss a few interesting cases here. So, this case was published in Toxicon, uh, acute neuromuscular paralysis, rhabdomyolysis, and long-lasting neurological deficits in Ceylon Krait, that is Bungarus ceylonicus bites. Two cases have been described here. So the Ceylon Krait, it is a highly venomous elapid snake, and this is quite common in Sri Lanka. Its bites are quite rare, and it is mentioned that only 7 reports are found in the literature till date. So here also neuroparalysis, the main clinical manifestation, and the two cases of proven Ceylon Krait bites. Two young snake peepers that worked in a serpentarium. So what happened was they developed acute neuroparalysis, abdominal pain, and a period of amnesia also. And in both cases, they were treated with the Indian polyvalent serum. So this is case one. As you can see in the picture as well, neuroparalytic features. So what happened was the person developed neuroparalytic features. There was myalgia and increased level of serum creatine kinase level as well, suggestive of rhabdomyolysis. And this person recovered with a long-lasting clinical disabilities. So what happened was there was impairment, the sensation of the bitten arm, and there was persistent refraction errors in the eyes. So there were long-lasting disabilities were there, despite his recovery. So in the second case, this is the culprit. This is the Ceylon Krait. And in the second case, there was moderate neuromuscular paralysis that reversed within 3 days. And luckily, there was preserved respiratory capacity in the patient. And in this particular patient, there was loss of memory for about 18 hours during the peak muscle paralysis, and he could not remember anything. He could not recall any details after full recovery of that particular period. And after full recovery of the muscle power, he had difficulty in reading and difficulty in also focusing the eyes. So this was the residual effect. Persistent marked nystagmus was there. Even after 18 months, this person had marked nystagmus. So this is another case published in the International Journal of Research in Medical Sciences, which tells us about the Indian common Krait envenomation presenting as fulminant myocarditis and coma. So in this case, this is a case about a 12-year-old boy, quite an interesting case. This is the boy. He was brought in an unconscious state 6 hours after being bitten by a snake, and he was bitten at multiple sites, and he was bitten in the middle of the night while sleeping on a cot at his home. And he was admitted. He was in a complete locked-in state, and there was hemodynamic instability as well. He was intubated and then mechanically ventilated. There were features of shock and also features of congestive cardiac failure. There were features of neurological examination. There were features of ophthalmoplegia, as you can see in the picture, and also absent vestibular, ocular, and coronary reflexes, and also bulbar palsy and quadriparesis was there. So this was caused by a severe neurotoxic snake envenoming by the Indian common Krait, Bungarus ceruleus. So this is the ECG of the boy with diffuse ST and T wave changes, and this is the chest radiograph showing bilateral alveolar opacities. This suggests pulmonary edema. So what happens? This boy was given the Indian polyvalent antivenom. Atropine and neostigmine were administered, and he also had recurrent episodes of sustained ventricular tachycardia, and this was treated with shock, and also he had to be loaded with amiodarone and also maintenance doses of amiodarone. So after 17 days, the doctors could wean him off the mechanical ventilation. So in this particular case, there was full neurological recovery, but features of congestive heart failure were still there, and he had to be on therapy. But during his 1 month follow-up, the patient was asymptomatic and his medicines could be stopped. So this is again an interesting case, but quite a different case of nephrotoxicity in a great bite. There is a rare case series of 3 fatalities in consecutive bites by a single snake. So 3 cases of deaths in the consecutive bites by a single banded krait in this case. So this, in this case, of the 3 victims, 2 were adults. One was a child of 4 years, and they were all bitten by the banded krait, and they were all brought dead in the emergency. It was a tertiary care hospital, but they were all brought dead. And this is the photograph of the cut section of the kidney. This shows the severe corticomedullary congestion and hemorrhage. So another case, this is a case from Nepal, a fatal neurotoxic envenomation following the bite of a greater black krait, that is Bungarus niger. So in this case, this is a case of a 33-year-old male person. He was under the influence of alcohol when the snake bit his index finger, and he developed bilateral ptosis. It was getting difficult for him to speak. His speech was getting slurred, and there was pain in the chest and in the abdomen also. And he also vomited once. So he was taken to the hospital, but unluckily, the antivenom was not available in that particular hospital, that local center. So he had to be transferred to a snakebite treatment center. That was around 4 hours after the bite. And then he was given the polyvalent anti-snake venom, and then atropine, neostigmine were given, but then he developed rashes, and the injection pheniramine was given. Antivenom was repeated 2 more times as per the case report, but then he suffered a cardiac arrest. Resuscitation was done, but he eventually died within 8 hours of the bite. So this is the krait Bungarus niger. Actually, this is the first report of Bungarus niger bite in Nepal, and only 6 proven cases of envenomation by this kind of krait has been published in Nepal and in Bangladesh. But it is said that maybe there are more fatalities, there are more case reports which have not been published yet. And so again, identification is the key. Identification is very, very important for a proper management. And we also know that currently available antivenoms, maybe they are unlikely to be effective against this particular krait. So this again is a report that was published. It's a report from Sri Lanka. It's a confirmed Ceylon krait, Bungarus ceylonicus, envenoming in Sri Lanka, and this results in neuromuscular paralysis. So this is a case report of a 26-year-old Sri Lankan man with confirmed Ceylon krait envenoming, and this person presented with other the neurological manifestation like bilateral partial ptosis, ophthalmoplegia, facial muscle weakness, and dysphagia as well. And there were tests like single fiber electromyography and repetitive nerve stimulation were also there that confirmed the neuromuscular paralysis. And he was administered the polyvalent antivenom, and complete recovery was observed in 3 days following the bite. So this is again a case from Rajasthan, krait envenomation. This is again a case where a snake passed over the body of the patient. There was no history of biting, any fang mark. Without any fang marks, the patient presented with neuroparalysis. Within 2 to 3 hours, he presented. And after they ruled out other possible causes, and then they diagnosed it as a krait envenomation. An anti-snake venom was given with other support as well, and the patient was discharged home, luckily, with no residual neurological deficit in this case. So from these cases, we all can conclude that identification is very, very important. So identification in the ER, in many cases, the snakes responsible remain unidentified, as I mentioned earlier. So there is clinical diagnosis, recognition of specific signs of envenoming in the patient, and there is laboratory diagnosis as well, like detection of abnormalities in the blood parameters, presence or absence of myoglobinuria, or changes in certain enzyme levels as well. and also the detection in the blood of the specific Venom antigens using immunologically based techniques such as enzyme immunoassay nowadays. So there is an article that was published in Toxins that is a review article regarding the diagnosis of snake bite and the importance of immunological tests in Venom research. So biodetection methods are there. They're considered for use in Venom research. Immunologically based assays to the detection of specific Venom and specific Venom antibodies. So agar stabilized precipitation test that was first used to detect a king cobra. Then diffusion tests, immunofluorescence, hemagglutination, immunoelectrophoresis, and also radioimmunoassay. These are some of the biodetection methods that I have just listed. And also ELISA, enzyme-linked immunosorbent assay, or EIA, that is enzyme immunoassay. These are also some of the tests that has been reported. And also a few more tests, the modified EIA, there is optical immunoassay as well, and PCR, polymerase chain reaction tests. These are also a few more tests. And talking about the snake venom detection kits, there is a kit known as the SVDK. This particular kit is based on the EIA test. And I would like to mention one more thing here is that if the test is positive, this result is not an indication for antivenom, because the venom detected at the bite site may be present in an insufficient quantity, and if even if it is negative, this does not mean that envenomation has not occurred. So because the venom may have been washed off, or it may be a bit diluted at the bite site. So having said that, the most reliable sample used in case in venom detection kits, these are the bite site swabs. But in our part of the world, it is not available in our part of the world. This is available actually in Australia, and this is also expensive for us actually. So these kind of kits plus clinical presentation, knowledge of snakes in the geographical areas, identification of the snakes to determine which antivenom to use. This is very, very important, especially in our part of the world. So there are lateral flow assays as well that can differentiate the hemorrhagic from the neurotoxic snakes. There has been a study by Liu CC et al. In 2018, this was published, that there is the development of sandwich ELISA and lateral flow strip assays for the diagnosing clinical significant snake bite in Taiwan. This was published. So if we have these kind of assays together with the observation of the clinical symptoms, again I repeat, observation of clinical symptoms, very, very important. We cannot ignore that. Lateral flow strip assays, these are applicable even in the emergency room setting, so that this will improve the snake bite diagnosis and the management. So regarding the management of the snake envenoming, we've already dealt with these important steps. The first aid treatment, which deals with the reassurance, the immobilization of the bitten part, and the rapid transport. Then the rapid clinical assessment and resuscitation, treatment with antivenom, supportive care, and treatment of the bitten part. So this is actually a picture in management of, while managing the snake envenoming, rapid transport is very important. So it's said that bitten by a snake, catch a motorcycle volunteer, reach the treatment center, save life. So motorcycle volunteer program to minimize the deaths related to snake bite, especially neurotoxic ones like in Krait's. It is motorcycle volunteer program. This is available in Nepal as well. And this can also be known as called as a motorcycle ambulance, basically. So this is again another article. This was published in the American Journal of Tropical Medicine and Hygiene that states the effectiveness of rapid transport of victims and community health education on snake bite fatalities in rural Nepal. So in Nepal, mostly in southern Nepal, most deaths are caused by neurotoxic envenomation. They occur in the villages or during transport to the health centers. So the effectiveness of victims' transport by motorcycle volunteers. So this article states the effectiveness of rapid transport of the victim by these motorcycle volunteers. So coming on to the antivenom, we all know about the big four. Antivenom, this is the only effective and the accepted treatment for systemic snake envenomation. We have polyvalent antivenom for the big four. This includes the common Krait as well. But there's no monovalent antivenom available yet in our setting. And talking about the complications, the antivenom related anaphylaxis, we have a study this was published in the Journal of Tropical Medicine. We have a clinical study which states the acute severe anaphylaxis in Nepali patients with a neurotoxic snakebite envenoming treated with the VINS polyvalent antivenom, which is the only polyvalent that is available in our country. This highlighted the risk of the severe anaphylaxis in neurotoxic envenomed patients, and also the challenges in managing patients where resources are limited. So it has been concluded that clinicians, they should have a low threshold for treating the antivenom related anaphylaxis when the clinical picture is not clear cut and ARE cannot be excluded. So again, one more case of allergic reaction to antivenom in a patient who was bitten twice by the same snake within a month. This is a rare case report published in the Chinese Journal of Traumatology. Quite an interesting case. So after this, this actually is a real case scenario. This is a case of anaphylaxis again, following anti-snake venom in a Krait envenomation and leading to VAP, that is ventilator-acquired pneumonia. This patient is still in the hospital. This is a real case scenario. This has been taken. This case is taken from a far western hospital of Nepal. A 72 years old female bitten by a Krait, and then anti-snake venom was received in a local hospital center, a local health center, but she developed anaphylactic shock after the administration of anti-snake venom. She was resuscitated, intubated in that local center, but she had already aspirated. After that, she was referred to the higher center. That was the hospital from where this picture has been taken. And mechanical ventilation, she was kept on mechanical ventilation for more than a week. She developed ventilator-acquired pneumonia. Broad-spectrum antibiotics were given, and the patient could be luckily gradually weaned off, and the patient was extubated. So this is the indirect. So this case shows an indirect relationship of anaphylaxis, following ASP leading to VAP. So there is an urgent need to develop novel strategies for the diagnosis as well as for the treatment of snake bites, and this has been published in Toxins again. And this was quite a recent one, published in June 2019. So this picture, this shows the past. It has been taken from the same journal, from the same article. This shows the past and the present treatment and the future treatment of snake bites. So if you look at the past and the present treatment, what we have been doing in our setup, present symptoms at the hospital, if there's ptosis or blisters, we wait for the symptoms to develop, use whole blood clotting test. In Australia, as I mentioned, we use the venom detection kit. We don't have that over here. And if symptomatic, we administer the antivenom or fresh frozen plasma, and we also deal with the complications. But in future treatment, we could rapidly diagnose with a detection kit, hopefully. And if applicable, to diagnose and take the appropriate first-line treatment, small molecular-based treatment. And we then go to hospital as soon as possible for tertiary care. There may be, where in the future maybe we will have monoclonal or other toxin specific treatments, and so advantages of future treatments. So we will be having fewer adverse reactions. We'll be having case specific treatments. that will increase the efficacy, and hopefully, it will eventually be cheaper as well. So, talking about neostigmine, in brief about neostigmine, this had already been dealt with earlier as well. We all know it is an anticholinesterase that prolongs the life of acetylcholine. It can reverse the respiratory failure and neurotoxic symptoms. And this is effective for postsynaptic neurotoxins. And we have this AN challenge where atropine and neostigmine is given. But there is a case I would like to mention, role of that was published a few years back regarding the role of neostigmine and polyvalent antivenom in the Indian common Krait, Bangaris cerealis bite. So this was undertaken to find the effectiveness of neostigmine. So the patients, they were managed with polyvalent antivenom and also 3 doses of neostigmine and atropine. And in this particular study, none of the patients, they showed any improvement following treatment, and all the patients developed respiratory paralysis, and they required assisted ventilation at all. And they concluded that it is not that effective in reversing or improving the neuroparalytic features in these patients with Krait envenomation. But this study had its own limitations, I guess. But in our practice, as mentioned earlier as well, neostigmine or glycopyrrolate or neostigmine or atropine, this is being used in the suspected or known cases of neurotoxic envenomation by Kraits with good outcome. So, having discussed about the management, the antivenom, the complications and everything, I still want to focus on the prevention part. Prevention is always better than cure, because in our setting, we have limited resources. Whether it is antivenom or whether it is any kind of diagnostic kits or a skilled manpower, we are very limited in case of resources. And we all know Krait bites. These are seasonal events. They occur when they come out of the hibernation after the rain. They are nocturnal. So the recommendations would be for community education, as we can see in this picture, and also awareness programs. And there is an interesting case report, a short report in Sri Lanka regarding the prevention of Krait bites by sleeping above the ground. Preliminary results from an observational pilot study. So in this study, this was conducted actually in 2 villages of Sri Lanka, in a district of Sri Lanka, and this particular district had reported a high number of Krait bites in the 2 years before the study, and most of the residents in these 2 villages, they slept on the ground. So what they did were they distributed beds. 45 beds were distributed to 45 families in this village, and so the 115 individuals, they did not have to sleep on the ground. So they followed these cases. 6 months follow-up visits were conducted, and this study, they concluded that there was a dramatic decline of Krait bites in both the villages. So what we can relate from this report, that better awareness with effective health education, clearing of the vegetation, they could have led to the decline in the number of Krait bites in both the villages. So this is the photograph of the donated bed that I mentioned in the article. We can still say that the positioning of this bed against the wall is not ideal, as the snake may crawl from anywhere, using the surrounding structures as support. But having said that, my take-home message will be, it is actually still better than sleeping on the ground. So this concludes my presentation. Thank you so much.